got our fellows here tonight, and it's kind of a mix of both operative, non-operative cases that we're going to present. So,
all right.
Okay, so we want to welcome everyone. We're live here from Seattle, Washington. It's the Seattle Science Foundation. And our first case is going to be presented by one of our outstanding fellows, Dr. Puriya Gayumi. We're going to mix it up a little bit tonight. So we're going to have some interesting cases that have had surgery, and we're trying to figure out what to do, and then some cases where we've operated on. And so we kind of want to show some things like complications, what to do. Look forward to discussion and questions on the live chat. So Puriya.
All right, thank you, Dr. Oskouian. My name is Puriya Gayumi. I'm one of the fellows here at the Swedish Neuroscience Institute. I have two cases to present. They're quite different. I'll start with the first one. So our first case is a 41-year-old female. She sustained a T12 burst fracture while she was getting out of her bed in May of 2019. She had no significant trauma. She also had multiple compression fractures on her lumbar spine at the time of evaluation. She had no neurological deficits on exam. In terms of pertinent history, she is 1.5 to 2 packs per day smoker. And she had a history of L1, L2 left hemilaminotomy done previously. So on her imaging, you can see on the MRI up on the top corner that she has a significant amount of compression, kind of at that T11, T12 burst fracture. And in the lower half, you can kind of see the prior hemilaminotomy side of the L1, L2. She still continues to have significant compression at that level as well. She was evaluated at an outside facility, and she underwent T11 to T12 laminectomy, followed by T9 to L2 posterior spinal infusion using the navigation and minimally invasive approach. Unfortunately, her postoperative course was complicated by a significant deep infection and wound dehiscence. She had to be taken back to the operating room for irrigation and debridement about 6 weeks later post-op. Her cultures were positive for MSSA. She was put on IV antibiotics long-term for 6 weeks and transitioned to PO antibiotics subsequent to that. Her back pain initially gradually improved, and these are the initial images kind of immediately post-op. However, these are her x-rays 6 months post-operatively, and you can kind of see that her most inferior screws are already pulling out, and there's evidence of a new compression fracture at that level as well. So she presented to our clinic basically for a second opinion, given that she was continued to have severe back pain and was developing this bilateral left more than right leg pain. She continues to smoke 1.5 to 2 packs per day. Her BMI is 44. She was put on Forteo by her primary care physician, given multiple compression fractures of her lumbar spine. She continues to be neurologically intact when we examine her in our clinic, and she has no bowel or bladder symptoms. So these are her most recent images, the CT scans that we obtained, and as you can see, she's starting to develop lucency around the screws. The screws are unfortunately pulling out. She has these new compression fractures around the surgical area, and also proximal to that at around T5 and T7. She is in severe pain and basically comes to us in terms of her treatment options. Her initial surgeon offered her that he can go ahead with removal of all hardware and kind of close monitoring, knowing that eventually down the line she might need more surgery and kind of more surgical fixation. So the question basically for this case is, what are the treatment options? Obviously, she needs a very extensive workup given her history of infection. She would require new ESR-CRP, vitamin D, calcium, DEXA scan, and most importantly, she has to stop smoking. In terms of treatment options, one would be just to do nothing for her and kind of conservative management and pain management. One would be what her surgeon offered her, which would be removal of hardware and monitoring without any additional hardware, extension of the current hardware or revision of the hardware. With the question with that, given And these images would be how proximal and how distal do you have to go, and do you have to do augmentation with cement, given that she's developing these new compression fractures postoperatively. And I kind of open it to the panel for.
That was great, Puriya. So I wanted to, Bob Hart just came in. I wanted to see what everybody thought. This is actually a patient of mine, and I haven't really kind of decided what to do. Go back to the original MRI. And it's kind of a, it's a tough case because she now has legitimate pain, and she hasn't really fused. And so I'm not in a rush to do anything. And she's still smoking. But, this is one of those clinics where you have like 40, 30 patients, and every time I go into an exam room, I'm like, okay, hopefully this one isn't as complicated as the last one. And she was like the last patient I saw, the day, and I was like, and she's only 41 or something like
41.
that. Yeah, and so I just, I wanted. There's so many smart people in this conference and in my group. I wanted to see what Bob says, and then maybe Scott or Scott Blumenthal or Sig, if you guys could comment. Maybe start with Dr. Hart.
Yeah, well, this was certainly a perfect patient to cap your clinic day with. And do we have the standing films? I was wanting to see the standing films now.
I don't have it on here,
Yeah,
unfortunately.
that's right there. That's a good one.
That's where we are now.
Yeah, that's, we don't have the full
So, I mean, clearly the initial surgery, I think, was indicated. It's unfortunate there was a wound infection. That's probably part of why she now has non-unions, it looks like, at several levels. A patient like this, you sort of can't optimize because they've got their neurology sort of trumps that at their initial indication. But I think you're absolutely right that now you have the benefit of time. I don't understand the etiology of her bone density deficiency, but clearly she must be osteoporotic. There are multiple levels of compression fracture already there. Very unusual for a 44-year-old. So that bears some investigation. The problem, I guess, if you define it now, is a combination of non-unions as well as the junctional failures, both at the proximal junction and at the distal junction, by the look of it. So I think taking out hardware and letting her optimize herself is not a terrible option. I don't think she's going to last without hardware forever. Would be my guess, and I think this has now become an alignment problem for her. And I think the ultimate treatment, if we get to that, would be a fusion from upper thoracic spine to pelvis. I don't think she needs a lot of realignment, maybe some posterior column osteotomies at sort of thoracolumbar junction there. I would work on her osteoporosis for at least 6 months. I would not operate on her until she was off of tobacco for 2 to 3 months. And I would also get her in a weight loss program and try to get her BMI down below at least 35. And there may be other issues here to optimize as well. That's what I would be thinking and talking to her about. So she's got a ways to go in terms of optimization. I don't think it's dangerous to take the hardware out. I don't know that it's dangerous to leave it in, but taking it out and sort of seeing how she does and working on those other features, I think that's a reasonable sort of way to temporize this.
Hey, Rod, do you have any information about how bad her osteoporosis was? Did you have the bone density? Because, I've seen patients like this that have horrible osteoporosis and they go one compression fracture after the other after the other. I mean, this gal's like, she's falling apart in front of your eyes here.
You won't believe this, but I think her DEXA scan was like within normal.
It was a couple years ago. She's pending a new one now.
It was normal when they did it.
Yeah.
Yeah, it's hard to believe.
Yeah, I mean, and has she been seen by an endocrinologist and worked up for other metabolic disorders? I mean, there's lots of reasons.
She went to the ER after she fell, and then Puriya showed the MRI. But, this kind of got read as, and again, it was kind of, you can see it there, we recently just had two great Canadian fellows, and, they brag about how, they basically brace every fracture that comes in. And, for someone like this, I'm not sure, for me, when you go back and look, it's always easy to second guess, but what do you guys think about do you think this is a stable or unstable fracture?
You mentioned in that, or that the presenter mentioned the history that the instrumentation was done MIS.
It was initially done MIS. Yeah.
So how my question is the biology of the fusion? How do you do a fusion if you're doing perk screws at 6, 8 levels? Because even if the surgery is indicated, and I see your point, Rod, that maybe it could have been braced because the person has problems more significant than the fracture, obviously the smoking, the obesity, et cetera, which you're probably not going to cure. And, I certainly understand the comment of getting them off tobacco and, improving their bone mineral density, although, you said the DEXA scan's normal. But my question is you do perk screws and probably not really getting a biologic fusion. And probably if you did a CT scan, I don't think you'd find any bone in the back. This was and you add the the imbalance of how the fusion was aligned. This was 100% doomed to failure.
So what would you do now, Scott?
Right, it was done outside. Yeah.
So would you leave it in, or what's your next steps in terms of what's the next thing to do?
Did she have a neurodeficit coming in for the fracture?
No.
Oh, she did.
Just back pain.
Oh, okay. Well, in that case, again, this is not as well done as we would like. I'm not against the idea, of instrumenting percutaneously something like this just for alignment as kind of an internal brace with a plan to remove the hardware at a later step. So clearly, we're at the point of doing that if we're going to, given the lucencies. And I think, given everything that you're describing, I think taking hardware out and following her for a while and just seeing how she does. And I agree. I mean, I don't know if they tried to get a fusion here or not, Scott, but I don't think it's an unreasonable approach to, rod long, fuse short, as the old paradigm went. And I've done that in other settings, and this might be one where that could have been undertaken. I don't know if that was the goal of the original surgeon or not.
Yeah, I don't know. This is a difficult one because just looking at her, I mean, she's a train wreck. She's got a lot of medical problems. So I kind of I did the stall ball maneuver, which is, I said, you need all the things that Rick said. She needed to see endocrine. She needed to get her diabetes and weight loss and quit smoking. And then bring her back.
It's interesting. I saw Sig on this call, and they've they're using AI and protocols for when they should do adult deformity. If you put all the comorbidities in with a fracture there's no neurologic deficit, this may be someone that you weren't going to operate on in the first place based on predictive analytics, and maybe Sig can comment.
Rod, I think in this case, she's got so many comorbidities that anything you do is going to end up in disaster. And this is one area where you almost have to put the onus on the patient that she has to do something for herself. Now, granted, there's certain things she can't control, like her osteoporosis, but she needs to have the responsibility and do those things. And I think, as everybody else said, whether you leave the hardware in or take it out, anything you do, I think, is going to be met with disaster on her.
And you can,
at least until she's optimized.
Yeah, and you can see on this on the CT scan, she's almost fractured every single vertebral body.
I know it's terrible.
Yeah. So, To be continued, but for now, we did the famous John James stall ball.
Push pause.
Yeah.
Good job.
All right, moving on to the second case. So this patient was a 30-year-old male with a history of IV drug use who came to the ED actually more than 5 days after a high-speed motor vehicle accident. So she basically was driving fast at around 60 miles per hour, hit a pole. At the time of the injury, he actually walked home and left his car and decided to self-medicate and with opioids for pain control. He did that for about a week to 10 days, and basically his family eventually, they decided to bring him in because he was bedbound and not moving and not eating and not doing anything. On presentation, he had midline low back pain. He had no weakness or numbness, no saddle anesthesia, no bowel or urinary incontinence. Physical exam was essentially benign. He had no neurological deficits, and aside from his tenderness over the lumbar area, he had no other findings. Hopefully the videos will work here. So on a CT scan, he has this 3-column burst fracture at L3 with evidence of retropulsion. And this the axial view. You can see the amount of comminution and retropulsion at that level. And these are the MRIs from the time of presentation, the ED. Once again, it's a 3-column burst fracture with about 50 to 70% loss of vertebral height and retropulsion at that level. And those are the axials at that level. So given that it was a 3-column burst fracture and he had severe kind of intractable pain at that time and inability to ambulate, the decision was made to take him to the OR and proceed with operative treatment. So he ended up undergoing L2 to L4 posterior spinal fusion with open reduction and decompression at the fracture site with segmental and fracture site screw at L3. And these are the CT scans post-op. In terms of post-operative care, he actually did quite well, and he was able to go home with his family on post-op day 2. So just a quick, brief overview in terms of classification of this thoracolumbar burst fractures. We here use AO classification a lot. Dr. Chapman wants us to know this cold. In terms of the classification, it uses morphology, neurologic signs, and kind of different modifiers. In terms of morphology, type A, B, and C, which includes compression fractures, kind of distraction, and tension band type fractures, and C is anything with displacement and dislocation. This kind of goes through the algorithm of assigning these modifiers or morphology modifiers. In terms of different modifiers, there's a neurology, which goes from neurologically intact to complete spinal cord injury, and the other modifiers, which is if it's difficult to tell if the posterior ligamentous complex is intact or not, this M1 basically is the indeterminate group. M2 is any other factors that may impact treatment plan, polytrauma, anything including patients who are AS in general. For this patient, I believe this would be an A3, which it's an A3/A4 burst fracture. The other classification that everyone's familiar with is the thoracolumbar injury classification and severity scale. Again, uses morphology, morphology and integrity of the posterolateral complex and neurological status. 4 is kind of the gray zone, and anything above 4 gets is usually indication for surgery. The other classification is a Load-Sherry-McCormick classification. This basically helps to decide if a posterior fixation alone is sufficient versus an anterior if an anterior stabilization is required. It grades the vertebral comminution in 3 planes from mild to severe. It was developed in 1994. basically grades the extent of vertebral body comminution, the amount of fracture displacement, and the amount of correction of kyphotic deformity. Fractures with mild comminution, kind of 6 and below, their conclusion was that can be approached with a posterior approach, and pedicle screw implants. Anything above is 7 should be have basically an anterior vertebrectomy and strut grafting based on the original paper was the recommendation. So the question with this basically is whether an anterior augmentation is required or whether a short segment posterior fixation is adequate for treatment of this. And in terms of, and basically the answer to that is that according to the literature is actually complicated. Proponents of the anterior column reconstruction argue that it's biomechanically more stable, potentially it has a higher rate of hardware failure, bent or broken screws, improved sagittal alignment with anterior column reconstruction, and you have better visualization and decompression if a patient is neurologically, there's any neurological deficit. However, most of these studies that showed hardware failure were actually kind of older studies, and they use older generation of pedicle screws. There have been biomechanical studies that shows a short segment fixation with a fracture level screw, improved biomechanical stability and sagittal alignment. There was a systematic review that basically showed no difference in respect to improvement of neurological deficits with anterior versus posterior approach. So in conclusion, in this case, you can, based on my assessment, based on my, you can argue either way in regards we can continue to monitor this posterior fixation versus we need to augment using an anterior reconstruction, most likely through a lateral approach. I calculated a load sharing score of 6/7, so it's kind of in that gray zone. And short segment fixation seems to be a viable option. You can utilize anterior reconstruction if there's high load sharing classification scores, or you can consider it in patients if they start developing kind of progressive kyphosis following a posterior only approach. Literature seems to support posterior short/long segment fixation with canal decompression through ligamentaxis in neurologically intact patients. Thank you.
So one of the reasons I wanted Puri to present this one is that he actually had a pretty significant amount of dislocation on the images and was quite unstable. And, you know, the reason I put one screw in on the right side is that if I need to do a vertebrectomy laterally, then we can do it. The other thing I wanted to kind of bring up for everyone, I think, you know, we're seeing a much higher incidence of younger and younger patients with IV drug abuse, you know, and it seems to be like a common theme. If you talk to the parents, they kind of start with marijuana, it's alcohol, and you know, but we have, I don't know if it's Seattle or what it is, but we have a very high population. And it's pretty sad. It's very depressing. You know, kids coming in on meth, using IV drugs, and we're just seeing more and more of it. So for me, you know, again, you know, do you go anterior, you know, and if you do, at what point? It was extremely unstable. And, you know, this isn't the patient that necessarily is going to see back in 6 weeks or 3 months. And so, and then we have a hard time, you know, like getting addiction medicine, inpatient psych. And I was wondering if the faculty and, you know, the group could comment on that, because it seems to me, it's like, okay, yeah, we're fixing this fracture, but then there's all this other stuff that goes on. And part of the reason I think he left on post-op day 2 is because he wanted to go out and inject. And it's such a difficult, you know, it's really a complex situation. I mean, the kid could not even get up out of bed before surgery, and I knew as soon as we operated on him, he'd be gone. So it's kind of, you know, there's a lot of social, psychosocial issues that we're now faced with as surgeons. And of course, you know, if he has a complication, you know, we get dinged for it. because he smokes, he uses drugs, he's got all the social, psychosocial risk factors. So I was wondering if you guys want to comment, and especially, I know you guys don't have this problem in Dallas probably, but the guys in San Francisco and
Yeah, Ron, I'll weigh in here a little bit, and I really empathize with the difficulty of this case and cases like this. Specifically, this is as much of a social problem as much as it is a medical problem. In terms of, at this point, you've stabilized him, you've taken care of the acute neurologic risk and the risk of progressive deformity, but there's a high risk that there's going to be progressive trouble. And, how do we create a situation where we can actually, is this somebody who maybe ought to be 5150 and put into a rehab? There have been some instances where, some good examples where this has been an opportunity for parents to get involved or for family to get involved. And other situations where, like you're dealing with, the patient leads AMA. I think this is something where the appropriate thing, is this patient in danger to himself by leaving AMA? And to me, the answer to that is yes, but I don't know if other people have had experience with this, but I've not been able to get people 5150 to stay in the hospital when they want to leave AMA after something like this. But this patient's clearly going to be at risk of progressive injury.
No, I did. I checked in right away.
So, Sig, what do you guys do at UCSF? Do you have like inpatient psych CM, and do you guys have like a protocol, or what's your, on a patient like this, how do you get the other services to engage?
Yeah, really difficult, as you're indicating, because in general, so this is something that I've probably seen more at the San Francisco General, where my partner Ashraf Al-Naga, who is up there at University of Washington for his spine fellowship, as well as Sanjay Dal, see a lot more of this at UCSF. But the experiences I've had have been me suggesting, hey, this is somebody who ought to be maintained in hospital as a mandate for their own safety, because they're not able to protect themselves. And at the same time, the psych service has not been willing to do this. I've had a couple of good experiences where I've engaged family, but otherwise, the psych service hasn't been willing to override somebody who wants to leave AMA. And I've had at least a couple of experiences of patients choose to leave AMA. One notable experience where I spent the majority of the night with a patient, convinced him not to leave AMA, that sort of thing. And it's sort of like when we're getting the police to deal with social problems, maybe that's not an appropriate place for the police to deal with social issues. So maybe there ought to be some sort of social service police force. I think it's the same thing with surgeons. Oftentimes, is maybe surgeons and medical system ought not be the first line. Our social workers really don't have many resources at all. They're completely hamstrung. And the best success I've had is with getting family involved when family are available.
So we just recently did this case, so we'll see how he does. But yeah, it's a very difficult social problem. And the other thing that's interesting, Sig, is that one of our fellows, Ronan Bletcher, wrote a great paper on, and people keep talking about how marijuana is this great drug, but the incidence of people actually developing schizophrenia, bipolar disorder, I mean, there's lots of papers coming out now. So I wonder if, and Ronan just wrote a nice paper in Spine that just came out, and we've seen that it's been like, I can't remember, it was like a 7-fold increase in spine infections since they legalized marijuana. So I wonder if there's like obviously it'll be hard to prove, but if there's like a correlation between, like people using marijuana and then moving on and using IV drugs, because I've never seen this before. It's like every time I'm on call, we get at least one IV drug abusing, patient who's got an epidural abscess or, osteomyelitis.
Maybe our medical system is driving IV drug use in two ways, because, of course, the opiate epidemic is characterized by more than 70% of people who are addicted to heroin started with a medical-related opiate prescription. So we're feeding it from that point of view, and maybe now in legalizing marijuana, that's another highway toward heroin and drug abuse. I don't know the answer to that.
Well, Sig, you scooped me on that, because I was just about to say I read a book called Dreamland by an investigative reporter named, I think, Sam Quinones, that basically chronicled how the Mexican drug cartel has followed the opioid epidemic in the U.S. and black tar heroin is, people get addicted to like opioids, and obviously we're more attuned to that now, but then they can't afford it after a while. And black tar heroin is much cheaper than the opioids, which is, you're absolutely correct. There's a huge percentage of the IV drug abusers that started with prescription drugs. And, in our pandemic time where we've got time to sit around and read, download this book called Dreamland. It's fascinating, because this investigative reporter, it actually comes down to like one small town in Mexico that they've got this sophisticated network in the US and they target cities like Seattle and San Francisco and other cities to prey on, and it's not always destitute people, it's affluent people and young people as well that just happen to get addicted to their drugs or their parents' drugs.
We did a symposium on this in NASS last year that John Devine from Georgia led, and the experience that John Francis from West Virginia shared was really strong in terms of the impact of black tar heroin on patients in terms of osteomyelitis and other major infections, including spine infections, orthopedic infections associated with IV use of black tar heroin and the contaminants therein. And so I'm glad you brought that up. That book Dreamland was part of that symposium that John Devine brought up.
Listen, for the naive opium people, what is black tar heroin? Scott, what is black tar?
According to this book, it comes from this one state, and I can't think of the name of the state, in Mexico, where it's farmed, and it can be made as cheaply as $10 to $15 a hit, and it's pretty pure, morphine-based heroin that, again, Sig was talking about the spinal implications of it, but if you take a little bit more than that, you end up ODing and dying. It's a very pure, cheap form of heroin, and I can't remember the state in Mexico where it comes from, but it's a previously poor area, which is now full of drug lords.
Wow.
So just to pull things back into the spine realm a little bit, when I have a patient that I don't think is going to come back to me, I probably wouldn't do a construct that is as short as that. I probably would do a longer construct, one above, one more above, one more below, and for sure fuse them, and probably think about fixed angle screws. What do you think about that?
That's a great idea. I didn't even think about it. But he was so young, and we got pretty good purchase. I think there were 8.5 screws, and we ended up using I think it was a 6.0 rod.
Yeah, hopefully you'll get away with that. You may never see the guy again, is what I'm thinking about.
Mike, although I don't do spine trauma, it sort of reminds me of my days when we used to do trauma down at Herman Hospital and even at Parkland. We knew that most of the patients weren't going to come back, so we did their final operation and try to make it as robust as possible. And Scott knows that too, having trained there, because you knew these people were either going back to Mexico or you'd never see them again. So you had to do their final operation and hope that they didn't break the construct.
That's an excellent point.
Yeah, I've got some issue going to L5 in this patient because the DIS5-1 was bad on the MRI, and then he's going to have terrible low back pain. I think you're much better off if you're afraid that it's not going to follow up and the construct may fail to do anterior corpectomy with cage, and then you can add anterior fixation as well to your cage. And this is very robust. It's not very aggressive. It's a small lumbotomy, about 2 inches long at the max. And then you have a construct that will not fail, and they don't get the steep spine above the sacrum. I try to do short for any type of spine trauma as much as possible, even if it involves anterior surgery, especially young people.
I would certainly agree that anterior construct would shorten your construct, and I think that makes a lot of sense.
That's an excellent point, Dr. Aile. So we've got a couple more cases to present. So Ravi Nuna, one of our outstanding fellows from Chicago, is going to present 2 more cases. This is both, again, these are kind of, one is more complex and then another call case. So Ravi, go ahead.
Thanks, Dr. Oskouian. So our first case is a very medically challenging patient. It's a 54-year-old male with a history of ESRD on dialysis. He's got a history of a right-sided stroke and resultant left hemiparesis, diabetes, which he's had a left TMA for. He had a ground-level fall about 6 weeks prior to presentation, and he came into the ED complaining of mid-thoracic back pain and the development of progressive lower extremity weakness. He had difficulty mobilizing with a walker, no signs of any bowel or bladder incontinence or paresthesia. On motor exam, he was strong throughout the right side, but he was diffusely weak on the left side from his previous stroke, 4 out of 5. He also had significant muscle wasting on the left, decreased sensation of pinprick on the left side, but no pathological reflexes. Imaging showed a complete collapse at the T9-10 level. As you can see on the x-rays as well as the CT. There was some question after the MRI if this was a malignancy or trauma-related, given the level of degeneration as well as the signal in the vertebral bodies. There was some question of a cancer-related diagnosis. Ultimately, the lesion was biopsied by IR to rule out metastatic disease or an infectious process. The biopsy was negative. The patient was placed in a TLSO brace, given PTOT, and ultimately declined surgery just because of his medical comorbidities, and he was discharged to skilled nursing facility. He presented back to the ED 10 days later with worsening back pain and ongoing difficulty with ambulation. During his admission, he ultimately developed acute lower extremity weakness and also progressive numbness and tingling. His lower extremity weakness went from about a 5 out of 5 to 4 out of 5 to a 1 out of 5. So he was barely moving the legs, still without any bowel or bladder involvement. Repeat imaging at this time showed progression of the kyphosis at the T9-10 level, as well as further collapse of those vertebral bodies at that level. And you can see here on the MRI the development of fairly significant critical canal stenosis at the T9-10 level. So the patient was taken urgently for a 2-stage procedure. The first stage was percutaneous posterior spinal fusion from T7 to T12, avoiding the fracture levels. This occurred without any issues. And stage 2 was a right-sided lateral T9-10 vertebrectomy. And you can see that 2-level cage at that level. Ultimately, after about a couple weeks on the wards, the patient did regain significant motor strength, and he was ultimately discharged to a skilled nursing facility with a motor exam of 3 out of 5 in the lower extremities, which was significantly improved from his pre-op exam. Just a little bit of literature review regarding this case. The minimally invasive lateral corpectomy has been tried before. It's been increasing over the last decade. One recent publication of Neurosurgical Focus, they compared 65 MIS lateral corpectomies with 9 open lateral corpectomies. They found that at 1 year, the rates of fusion were similar. However, the MIS cohort had a decreased operative time and a decreased time to ambulation. Notable complications in the MIS group were 1 screw misplacement requiring revision, 2 postoperative femoral neuropathies, as well as 4 pneumothoraxes that required chest tube placement. For our case here, they actually went ahead and dropped the lung preoperatively, and they just placed a chest tube just for improved access. The only other study was by Yu et al. At a World Neurosurgery in 2019. This was a cohort of 20 cases, also for unstable burst fractures. This cohort had no complications, and they compared fluoroscopy and intraoperative CT navigation, found similar outcomes with traditional fluoro and ICT for this patient group.
So,
do you have any axial images postoperatively? How well do you think that you were able to decompress that with percutaneous posterior and MIS lateral? Preoperatively, there was obviously a significant neurologic deficit. It wasn't that terribly stenotic, but a lot of deficit there. How well do you think you were able to get some of that posterior cortex, some of that retropulsed bone, as well as presumably infected material, but going perc posterior, so leaving all the lamina, and by doing MIS lateral, do you really feel like you did a good job of getting into the epidural space?
So in regards to decompression, they did do
indirect decompression.
Yeah, they did do an indirect decompression. In addition to, during the first stage, there was also a hemilaminotomy performed to give some more space. But in terms of the retropulsed elements, I think we were depending on indirect decompression.
So Sig, I wish we had, do we have the MRI? So this is a case that, you know, I've never been a big fan of indirect decompression, but this is one case where I have to say I was blown away by the post-op MRI and CT scan, because all that bone, even though it's there, you can see it. Ravi, go back. And Sig, this is why I presented this case. There's a spiked disc and bone in the back. Is by going anterior, that back wall, you know, however, you know, I think just by indirectly, you know, pulling up the anterior column, that back wall sucked forward. You know, you're right. I mean, there's still bone there. You can see it. But I think this is one where, you know, that's why I wanted to present this, because I think indirect decompression sometimes works. I'm not sure necessarily in a patient with a deficit. I personally would probably want to, you know, take more bone out. But, you know, we got this case to, and the patient actually improved after surgery. Do we have the MRI by any chance? No.
I don't have
okay.
It here.
So, but yeah, Sig, I mean, these are good points. That's why I wanted you guys, show the pre-op CT. Look how much height restoration we got there.
It's beautifully done from a technical point of view. I think, and clearly you were able to really get those the posterior walls lined up. I might not have anticipated that lining up quite as well, but presumably there was some posterior longitudinal ligament that gave you some ligamentaxis. You know, Rod, I think you did a beautiful job there. I think technically that's exquisite, and all MIS with PERC. I'll tell you that in general, this is something that I tend to feel a little more comfortable with, just dealing with all in the back and kind of pushing everything away from the cord. Still do the vertebral column section, but all in the back. And what I really think about is shortening the cord. One of the things, especially if somebody's got a neurologic deficit, I'm really cautious about it, and you know as well or better than I do, is you know trying to avoid putting tension on the cord, but rather I almost try and get that. If it's T8 there, that's the fractured vertebra. I think you could just see the top of T7. Is that right in terms of levels? But I would actually put a screw into that, the vertebra that's got osteolysis below it, put a screw into the pedicles on top there, and then really shorten that down to the vertebra below and do a posterior-based VCR, trying to shorten the cord, especially with a deficit. I agree. Your technique was really elegant, and it's impressive how well you were able to get that lined up.
And the guy was very sick too, so I think we wanted to stage it and try to not as much decrease the amount of blood loss that we had during surgery.
What was it? Infection? The diagnosis?
It actually, I still think to this day, I don't think anything grew out.
No.
And so I think it was probably like a burned out osteomyelitis, and it was, maybe it was infected at some point, but I don't think anything grew out.
It could be renal osteodystrophy too.
Yeah,
if you
that's true.
Amyloid. I don't know if you guys sent biopsies, or you did have a biopsy.
We did, yeah.
Said,
We sent everything.
Yeah. I mean, I probably would have done this similar to what Sig's saying. I would have done it with a costotransversectomy and probably a 2-level corpectomy. And not knowing the patient and not knowing how sick you may have been. I mean, this, again, it is a very elegant solution. I suspect the postoperative CT is better in the midline.
It is actually. You can see really, this is not a.
It's not really a midline cut. Yeah. So I think the alignment and the elevation you got is probably has restored the canal diameter. And again, the proof's in the pudding. So the fact that he neurologically improved acutely post-operatively tells you, I think you got him pretty well decompressed. Yeah. So
Ravi, go back to the original. What's crazy about this is that, this guy was so sick, keep going back to the MRI, that, we didn't want to do anything on him. And, I mean, he was a train wreck. And, I mean, we were like, literally every time this guy has a procedure, he has like a massive, complication. And so, is that the original? Go back to so you can see how much he collapsed in such a short amount of time. And he came in, almost paraplegic. And so it was just one of those cases where you're like, really? After, such a short amount of time, the guy, and I thought for sure it was either an infection or a tumor, but so far he's doing fine.
He really forced your hand. I agree with your assessment. I would not have predicted that progressing, so I agree with your initial management.
Yeah.
Ruling out tumor, ruling out an infection, and then
the CT scan was a lot worse because I remember there was you could see there, and this is the other thing too. I don't know. It's I've now with all these infections, I try to get our guys here to biopsy these lesions, but it takes forever to get a result. And I think by the time this guy came back, nothing grew out.
What's your experience been with having CT having radiology do a biopsy versus doing it yourself? If you look at the literature on this, almost 30% of radiology based, they use a fine needle aspiration and they don't get a whole lot of tissue. I tend to, in a lot of these cases, I'll actually bring it over myself and do a biopsy, and it doesn't take much time. I'll put it in another room and just really try and get some good cores from multiple levels. When I try and get the CT guided people to do it, they get small little aspirates.
Yeah, that's a good point, Sig. I've never thought about that. Our guys here do it under CT, and I don't know what they use, but they usually we don't have a problem getting enough sample. So, to be continued, we still don't know how that guy's, there's all this, obviously his bone quality's not great. We got to get a fusion to take place there anteriorly. So the next case is actually a patient of Dr. Hart's. So.
All right, thank you. This is a 53-year-old female, past medical history of IV drug use, endocarditis, and recurrent MRSA bacteremia. She's got an extensive spinal history comprised of 19 spine surgeries. She's had multiple bouts of osteomyelitis, discitis, epidural abscess, EVACs, and then just a very, very complex history of instrumentation, removal, and re-instrumentation. So I believe Dr. Hart inherited her very, very late in terms of her most recent case, actually.
Thank you for clarifying that.
So she presented to Dr. Hart with chronic back pain, bilateral rod fracture, and recurrent MRSA bacteremia. The infectious disease team was concerned that her L3 femoral shaft allograft may be the source of her recurrent bacteremia, which she was on chronic suppressive therapy for. Her imaging showed primary fusion construct from T4 to S1. There was a cage at T11. There was an L3 femoral shaft graft, interbodies at 4-5 and 5-1. And there was also a quad rod construct with auxiliary rods spanning from T12 to the pelvis with iliac screws. Her neurologic exam was surprisingly without any deficits, and she was full strength throughout. These are images of the concerning L3 graft. As you can see, there's lucency around the entire implant, and the bone has not integrated this graft significantly. This is, however, posteriorly, she actually showed very good fusion throughout her posterior fusion construct, with the exception of the rod fracture. These are images of the fractured bilateral auxiliary rods you can see on both sides, one at L3 and one at L4. So the primary considerations for this case was that the previous L3 graft was placed via an OLIF approach, and it required removal and replacement. And also a consideration was that given her previous surgery, there was going to be extensive adhesions and scar tissue, both during the approach and around the spine. And in addition to that, she required posterior reinstrumentation with repair of the auxiliary rods. For surgery, we replaced the graft with a tibial strut graft, and granulation tissue that was surrounding the previous graft was sent for cultures. These cultures are so far negative in terms of any kind of infectious etiology. In addition, the posterior reinstrumentation was performed for new auxiliary rods, in addition to new upsized screws for the majority of the construct. So she's doing well post-operatively. It remains to be seen if she has any further bouts of MRSA bacteremia, but definitely an interesting case in regards to the usage of the OLIF for placement of the L3 graft. So just to review a little bit about the literature, as we all know, the OLIF is an approach that uses anterior to the psoas muscle and is associated with less deficits in the psoas. Previous literature that has compared the OLIF and the ALIF. This is one study out of China. They found that the OLIF was associated with similar operative times, length of stay, fusion rates, and complication rates. And at L5S1, they found that the ALIF allowed for larger cages to be placed, resulting in a greater disc height change, but overall no difference in 5-1 segmental lordosis. The largest series of OLIF patients is also out of China by Zhang et al. This was a paper out of this year. This is 235 patients, and they had 91 OLIF alone patients and 144 OLIF patients with posterior fixation. And this was just an outcome study, and their most common complications were vascular injury, end plate damage, vertebral body fracture, nerve injury, cage subsidence, transient psoas weakness, and 8 cases of reoperation. So definitely a developing procedure that's most likely going to be increasing in frequency.
So I'll add a couple of points. This was, we did this, I don't know if I would call this an OLIF, what we did. The prior surgery was, we used an OLIF type retractor for sure. But I actually asked an approach surgeon to help me given the revision status, and we put in a ureteric stent on the left as well that turned out to be very helpful during the anterior approach to avoid injury there. We didn't find the bone graft swimming in pus, right? But there was definitely some granulation tissue around it that was chronic, that may have been infection. And then we used BMP here in the front as well as structural allograft, which is, I use expandable cages in a number of settings, but given the history, chronic infection, and the biologics of the situation, I wanted to make sure that we had as much bone there as we could get. I'm not sure that she's fully fused in back. You see there, the facets certainly look good, a lot of these levels, but I do think that maybe, particularly at the 3-4 level, there's a persistent non-union. I think it may be that even with a solid fusion in back and without posterior or without anterior column structural support, you end up with a hardware failure. I think this is the first woman I've had with quad rods that has come back with a hardware failure. So it's hard to fail 4 rods, right? But she clearly did it, and she's a tiny little woman, the last piece of this is that we had to undermine the posterior musculature and really do essentially a flap of the paraspinal muscles in order to get her deep tissue up over the implants, because they're really quite bulky now. So I think it's not a perfect outcome. I hope we'll see, and we'll see how she does clinically. But I inherited her with, I guess, no instrumentation in and persistent MRSA infection and spinal cord compression at the side of that expandable cage, and I did put that in via a posterior approach, and then re-instrumented to span the posterior column down to the pelvis as shown. So that's where she's at.
So do you guys normally, I was going to ask Bob, did you do the closure yourself?
Yeah.
So you closed for the 20th time? Wow.
Yeah. Yeah.
So what's your protocol for cases like this?
I would prefer to have a plastic surgeon help me with the closure, and would have done so in this case. Our current closure expert is on personal leave for just at the moment, so we weren't able to get him back in. But yeah, after a day's work to have to do a plastic closure was so.
Yeah, it's a challenging problem. And I don't know if the group, Sig or Scott or Rick, but we got these multiple patients who've had, this was 20th surgery. It's almost impossible to find a plastic surgeon that would be willing to engage in such an event. Because usually it's at like 6 or 7 o'clock at night. We're closing up the wound.
Yes, it's a really important challenge that you're asking about. And we do a lot of close work with plastic surgeons. But at this point, the plastic surgeons are pretty clear about the fact that they don't want to be starting anything after typically about 3 or 4 o'clock in the afternoon. It's a tough challenge. It's definitely something worth trying to schedule with the plastic surgeons rather than asking for last-minute consult for sure.
Yeah, I think her paraspinal muscles were like cardboard. Yeah, I think we started closing at about, 4 p.m., I guess. And I think we got to cut about 10 a.m., right, with the waiting for the ureteric stent. We did that first in the OR yesterday.
Was it helpful to use the stent?
Yeah, it was beautiful.
Can you see it on that AP?
Yeah, you can see it.
Where is it?
Can you show it there, Robbie? Can you point at it?
Is it that thing right there?
With the cursor?
Oh, yeah. It's on the, you did a left-sided approach? Is that it right there?
No. It's this.
Oh, yeah, okay, wow. Did it take them very long to put the stent in?
I guess about a half hour. About a half hour, I think.
Wow. Do you always do that because you're doing an oblique?
For revision anterior.
For revision anterior, really?
Yeah.
And you do it on the day of surgery?
I think that's the easiest way because it's a general anesthetic procedure, and so just doing it as part of the operation. Yeah.
Wow. Great case.
Unbelievable cases.
To be continued, right?
Yeah.
We still, so that was a stable non-union, is that what you would say?
I think you could call it that, right? I mean, obviously the rod fractures, but, again, I think she is fused posteriorly, but I don't think the bony fusion posteriorly is going to last if you've got enough mobility anteriorly to allow her to fracture her rods. I think that's going to progress, so I don't know. I just hope this woman heals and stops showing up in our ER. She's actually very pleasant, except for the fact that...
I know her.
Yeah, I think we all do. So she's pleasant, except for the fact that she can't seem to heal her spine. I don't know.
Great. Thanks, Ravi. Great presentations, everybody.
Yeah, unbelievable cases, guys.
Great cases.
We're glad they're in Seattle, not in Plano, Texas.
Great to see everybody again. I wanted to especially call out Mike Eisey, my former classmate and friend from San Diego. I haven't seen you in a great number of years. It's great to see you out there.
I'm here, man.
We got to get you up here to visit sometime.
Great cases.
We want
I've
an
been up there,
update on
but
Dak
great cases.
Prescott next time, guys. Yeah. Scott, we need an update on Dak, okay?
Just an ankle fracture. I had the same fracture a few years ago. He'll be fine.
Okay, good.
Yeah, I think he'll be back next year. I mean, I talked to
listen,
sports
Mike's
guys
a spine surgeon. He's fine.
He needs to get more money from Jerry. Come on. We got to get some
I think
guilt
actually
money.
it's going to be a good deal for him. He had such a strong start of the season. I think there's no way he cannot get paid now.
Yeah, all we need is some
Contract
defense.
time.
We'll be okay.
All right, guys. Thanks so much.
All right, take
Good
care.
night. Well
Have a
done,
good evening.
Seattle.
Be
Great
safe. See you
conference.
Friday.
Thank you.
Bye-bye.
See you guys.
Thanks for watching. Hit the subscribe button for more medical content.